Great. I'd like to take just a few minutes to introduce our speaker today on the call. I'm sure all of you are familiar with Eric Schell. Eric is a principal at Stroudwater & Associates, and he has over 22 years experience in healthcare financial management and consulting. Since joining the firm in October of 1997, his areas of responsibility have been in assisting rural hospitals, rural health clinics, and physician group practices improve financial and operational performance in developing strategic and operational plans. Eric is often featured as a speaker at our State Hospital Association, State Office of Rural Health, and Rural Health Association conferences. And I'm really looking forward to the information he has to share with us on today's call. Eric, I'm going to turn it over to you, and I'll get your screen up just in a second here.
There it is. We ready to go?
It's all yours.
All right. Thank you, Allison, and thanks for those of us who are choosing to listen in on this call. This talk is a really interesting one. My colleague and I developed it a couple of years ago, and when we were looking at some relationships between large hospitals and smaller hospitals, and we saw a whole lot of not so good relationships going on, and we decided to sit down and pull this together to really look at where in affiliations or relationships between two organizations you can extract value and how best to go about that. And so the outcome of this was this presentation. We've presented this now, and increasingly, I have to tell you, in the last 6 months, I've probably presented this talk 4 or 5 different times, either to networks or other bodies, because this has become the hot topic right now in rural hospitals, and it's particularly with critical access hospitals. About a year ago, well, one thing, it's a little bit of a difficult presentation. So here's a consultant speaking to you at lunch telling you this is going to be a tough presentation. But it's a tough presentation because it's a lot of theory-based at this point. As more and more hospitals are affiliating right now in the rurals, we're getting more experience in this. But there's a lot of theory built into this. But I will tell you that about a year ago, I was presenting this to the COO of a large health system in Jackson, Mississippi, and this gentleman actually said, "Boy, the value of this presentation is in the details," and was very excited about understanding the details of this talk. So I'm asking you to be patient with it, but also really step to understand the details because there's a lot here. So kind of with that as an introduction, and I do want to say, feel free to unmute your phone and shout out if you got a question or you're thinking about something, because I really don't like talking straight for 75 minutes. I prefer that other folks jump in and kind of have some discussion with us. So anyway, with that all as an introduction, let's take a look here at the next slide, and really what we're looking at today is what is this affiliation value curve, and how does it work? And I want to give you a little bit of history about where that came from. Look at what's going on, these affiliation drivers. What's going on right now in the industry that I will tell you in the last 12 months, this has been a hotbed of activity. I've got, I was just in Pennsylvania last week working on a project like this. I was in Kansas the week before working on an affiliation project. I mean, it's increasingly, a lot of my work now is going in this direction because of a lot of drivers. Going to look at this as a strategic option, and I want to show you on a contribution margin how to think about the value that rural hospitals have to a larger system. And I think it'd be, often we see rural hospitals kind of go with cap in hand to larger systems, and I want to make sure that nobody thinks like that. And then some questions. And when you're thinking about it, some type of a relationship, what are the questions that we ask, and how do we ensure that if we go forward, it's effective for both us and our partner, whoever we choose to have a relationship with. So that's the overview. That's what we're going to get out of today, hopefully. The affiliation value curve, at the highest level, it's essentially a diagram that frames where value is generated for a rural hospital and a partner hospital in a relationship. And it also plots it along kind of levels of commitment. And essentially, our belief is that the higher levels of commitment that are created, the more and more value that can be gained by both parties. It also provides an objective framework for how to think about value. And I often ask boards to sit down and really go through each of the kind of areas where we can generate value and assess your own strengths and weaknesses. And essentially look at how, well, really just assess your own strengths and weaknesses. It's a very interesting exercise. The point about what we're finding is a lot of affiliations right now are primarily set up to be more tactical. They haven't reached the strategic level, and I'm going to talk to you a little bit about what that means. And I think on an operational basis, it requires much less commitment, but at the same time, a lot less value generated. The strategic initiatives are kind of much more commitment, much more time-intensive, capital-intensive, but ultimately at the end, I think it's going to be the huge value, especially as the future of our whole healthcare reform and that plays out. So with that, I'm going to show you a picture of the affiliation value curve just so that you know, kind of see where we're going, and then I'm going to take it away from you, and then we're going to walk through, we're going to kind of backtrack and talk a little bit about what's driving this thing. And so when I'm going to, let's see, we're going to pull this. I have an arrow here, hopefully. So we got the arrow, everyone see my little arrow there floating around? When my colleague and I first started designing it, let me show you about the plots. The first is on the x-axis. It actually shows the level of commitment. So as we move out on the x-axis, it requires higher and higher levels of commitment. The y-axis is essentially value that is gained from some type of a relationship. And when my colleague and I originally started thinking about affiliation value curve, I think if you know any Brian Hopler or myself, you know that the only thing we were really concerned about was this half, the top half of this curve. We didn't even think that there was a lower half. What we were thinking about was for rural hospitals, where are all the opportunities for value to be gained in a relationship? And you can see kind of on the left-hand side here, you can see some of these, and what we consider these as more operational, and we've got this commitment gap, and I'll talk a little bit about that. And then on the other side, we get to much more strategic, but at the same time, what we believe is potentially much more higher value nodes. So what you got here is the rural hospital. The rural hospital is on the upper side of the affiliation value curve. We've got the different nodes of value that can be created, plotted here, with how we interpret it as potential benefits to be derived when we do each of these right. We've got operational and then much more strategic here where the value seems to go. So for about a year, my colleague and I were thinking, boy, we've got this thing all figured out. We're just going to focus on rural. And then we sat back and said, you know what? For every value add or opportunity for value add on the rural, for example, image, there's a related value add to a larger system or the system, the partner. And as we plotted this, what we came up with is there's a mirror image value to every value that's added to the rural. There's equal value added to the larger system. And it plays out to the point where essentially when we get out into these far strategic value opportunities, the combined value creation is enormous for both organizations, but at a higher level of commitment, as indicated by this right here. So anyone have any questions on just kind of the overall what this looks like? You're going to hear me talk for 75 straight minutes if nobody has any questions.
I don't have a question. I'm just saying, I'm this Chip Denton. I think it's very intuitive. It makes a lot of sense.
Well, I think like I said, I was really amazed because when we sat down and said, wow, and we're going to go through each of these notes here in a minute, so we'll explain them. But the whole idea and what really formed here was the thought that rural hospitals have huge value in a relationship. And they don't, most of the time, the rural hospital doesn't understand that value that they bring to the table. And so anybody that walks out of this call here today, I hope that's something that I completely kind of leave as a leave behind. So now I'm going to take away the affiliation value curve, and we're going to talk a little bit about what's driving some of this. And then we're going to go back and walk through each of the nodes before we start looking at potential contribution margins or contributions to a larger system. So first we've got internal factors, both internal factors at the large hospitals and internal factors at the rural hospitals that are leading to this. One is the first thing, this historical image leading to out-migration. Every time I go into a rural hospital, somebody at some point during the course of the interview say, yeah, my friend down the street said they wouldn't bring their dog to my hospital. And so the question is, with a new relationship and a different logo on our front door, does that immediately change how folks perceive our hospital? One of the big areas is this gaps in management expertise. Often rural hospitals don't have that. They don't have that human resource director that knows about the ERISA laws and everything coming down the pike from a legal perspective as it relates to human resources. It's about the corporate compliance officer and the in-house legal expertise and all of this that we can't afford in rural America. And often that leaves us gaps. I was working with a hospital system that owned 3 critical access hospitals, and I did a project last fall where I went out and I talked to each of the 3 critical access hospitals that were owned by this system. And one of the things that you heard from the administrators of the critical access hospitals was they sleep at night knowing that they've got that the bigger system has their backs. One gentleman was actually from an independent hospital in another state, and he said he would lay at night worrying about all of this stuff that they don't have to worry about anymore because we've got a lot of folks backing them up. The third area of internal factors is operating imperatives to increase efficiency, and this really comes out of healthcare reform. What you've got essentially is healthcare reform is saying, first we're going to do more, you're going to do more with less, and then as we transition our payment systems, the extent healthcare reform is implemented, we're going to require, you're going to be doing less with less. But ultimately, less is going to be the main word here. And so we had a 3-hospital system in Maine here. They were actually not critical access. They're all 3 tweeners. And they got together, and well, they're talking to each other, but what they want to do is they essentially feel the need to take costs out of the system. And so they're talking about kind of maybe possibly combining revenue cycle functions or creating one central business office or centralizing functions, but ultimately the need to increase operating efficiencies. The need to recruit medical staff or access visiting specialists. Clearly rural hospitals, I don't think there's ever been a rural hospital that I've visited where there wasn't a need for some type of visiting specialist that would actually do some cases or minor procedures in our rural hospitals. On the larger hospitals, they can generate income for, what they have is they have management expertise. They have the super skills. They have the corporate compliance officers. They have the in-house legal. And what they have is the brains in their head that we can share and we can leverage those. And frankly, the larger systems can resell that, either through a direct management contract or frankly through the cost report, through a home office cost shift to the extent that we're a critical access hospital. And then possibly this whole inpatient crowding. And a lot of larger systems are running very high levels of occupancy, and to the extent that we can farm out some of, especially the rehab and the swing bed type care, opens up space in those. So I had a system in Colorado that I worked with, and their big point, they had 3 critical access hospitals in their network, And what they ultimately said is that we do tertiary care services. We're going to do everything we can to keep primary medical inpatient and outpatient services in rural, and we're going to keep that out with them. We're going to push stuff in our place that goes into rehab back out to them, but we want the stuff. We want the heavy duty stuff, and they were the most profitable system in Colorado. So a lot of internal factors leading to affiliations. I think the external factors are the main reason that we're seeing this industry trend right in the last 12 months, where we're seeing this going on everywhere. One is competition, to protect or expand market position. I was in Pennsylvania last week, and a new highway had been built between these two larger communities, and a critical access hospital sat right between them, right on this new 4-lane interstate highway. One of the systems said very clearly, boy, we're really interested in having this critical access hospital in our fold to keep that other system away. So it's about, kind of capturing market share and market position. Our rural hospitals, the access to capital to both modernize our facilities and information technology, huge opportunity and external factor. And then the governmental, the pay for quality, the accountable care organizations, healthcare reform and system restructuring. This is where we're seeing, I think, the greatest change. And it's all about, if you think about our rural hospitals in the land of health reform and accountable care, what we are, frankly, is primary care-based medical homes in outlying areas. If we think about in the future, to the extent the accountable care takes hold, value is in primary care physicians who have patients assigned to them. That's where value is actually created. In our rural hospitals, if you think deep down about them, we're primary care medical home models in which in the future with accountable care is going to be huge value. I know people are going to debate, well, these accountable cares aren't going to go anywhere, none of the big systems are interested. I think that they're going to have more legs than folks think, because I think CMS is going to listen to folks and make some changes. That was the word we heard at the NRHA's annual conference in Austin from CMS folks, that they were interested in what was going on and interested in making some changes to make this, the accountable care, something that works. Demographics, protect or expand market position, and technology, the whole electronic medical record, and the funding of that, and frankly, the skill set to implement that. All external factors driving affiliations. Anyone have any thoughts on any of that? Because I think those are pretty important drivers. And again, something has shifted, because in the last 12 months, this is just a hotbed of activity, as I mentioned earlier.
Eric, this is Chris Tilden. Just a comment.
Chris.
I agree with you fully that the external factors are really driving a lot of the interest and a lot of the opportunities. I think it is interesting how, if you look at the environment, how some of the internal factors you also talked with potentially are also gaining greater importance just because of things like regulatory scrutiny. And for example, I mean, you mentioned the increasingly regulatory environment around HR. I don't know how many of you saw it, but last week, I'm trying to think what organization it was, some large national retail chain that was fined over $1 million by the Department of State for improper completion of I-9 forms. I mean, think about how innocuous that I-9 process seems and how simple it seems. The piece that I read suggested that upwards of 80% of I-9 forms are completed improperly by employers, and there is basically a per mistake fine that the Department of State can levy on employers for improperly documented and completed I-9 processes. It's becoming such a regulatory environment around things like HR that having that expertise in hand is just absolutely critical.
Chris, absolutely. And as a consultant that really doesn't know anything, what's an I-9?
It's the process by which you verify that an employee is a legal resident of the United States.
Okay.
And again, it's a simple form that's completed, has to be turned in the initial day of hire or first day of work. And you know, on the surface, it looks so simple. To hear experts say that 80% of these forms are completed inaccurately, and those inaccuracies can all result in fines is pretty scary to any employer, I would think.
Absolutely. Yeah. So anyway, lots of stuff. Like I said before, there's so much activity going on in this area. So lots of drivers going on. What the intent of this slide is really to show is that this is a line that plots out rural hospital performance. And what it's saying is that when the hospital is operating in this range, and this is a range in which they're easy, they can pay you their debt service coverage ratios, they're doing really well financially. And when rural hospitals are kind of in this way up here range of performance, they have all kinds of strategic options related to any type of collaboration or affiliation. As you go down and financial performance deteriorates, and as you get out, and as we get out to the right side over here, these are the critical access or rural hospitals that are essentially saying, I'm not going to make payroll 30 days from now, and this is not uncommon. We're not going to make payroll 30 days from now. We're going to take the first offer and jump on it. And ultimately what we ought to be doing is if we're thinking about any type of relationship, we are going to be doing it while we're in this range up here, while we have many options. I was at a system this week over in Missouri, and they were interested in lots of affiliation activity going on all over that area. And one of the this hospital has gone from a positive operating margin of around 6% to a negative operating margin for 3%. And their board members were saying, kind of what's your affiliation strategy? What should our affiliation strategy be? And I said, your number one affiliation strategy is to get your financial performance turned around so that your operating margin is 2%. Then you can talk to anybody. This gets back to Stephen Covey's circles of dependency, where you have your first circle is your dependent, the second circle is independent, and then your third circle and most valuable is your interdependence. And essentially, if you're down in this position, you're really dependent, and it's no position to go into any type of relationship. We really want to think about relationships when we're completely independent, because that's where we bring high value. And so that's really what the intent of this was. Let's start having conversations, or at least understanding our options when we're successful financially, rather than then we're in a desperate grab. So now what I want to do is as quickly as possible, because this is where it might get a little monotonous, is kind of walk through the affiliation nodes of value. And talk just a little bit about each one. The first is it's branding and franchising, and what we've got here at the first node is what we see is rural hospitals by hanging a new sign outside their front door and being engaged with some type of affiliation. There's the impression of the improved image. Ultimately, what we're trying to do is leverage the larger system's reputation and brand for the benefit of creating a halo effect or a volume. We hang the Mayo Clinic banner outside of LaSalle General Hospital. Hey, Billy Page, I saw you joined in. Hope you're doing well. And all of a sudden, LaSalle General Hospital, an affiliate of Mayo Health System, is just something different than it was before we went in. Often this is framed in an informal, monthly meetings, marketing and sales. It's a very, very loose affiliation. The value generated from the larger system is that they can distribute their franchise. So what happens is this regional brand, and they're looking to increase the probability of referrals from your service area. I mean, ultimately, that's what this is about. And in the future, frankly, it's not even the referrals. It's having the relationships with your primary care physicians. Again, increasing the perceived scale and protecting against competition. And again, informal communications. What we're seeing, these often, their CEO or CFO or some senior management team sits on our board or attends our board meetings. Very loose relationships. The situation here, obviously, a rural hospital looking to improve its image and brand. Referral hospital looking to distribute its brand. The characteristics: loose affiliation, signage. Routine interactions between management teams, member of management teams, responsibility to board meetings, very, very loose relationships. Benefits, often at this level we can start, often the larger system will often offer education and other general support. Again, that opportunity to redefine community image overnight. It's the kind of thing that instead of taking years, 2 or 3 or 4 years to turn around our image, it often can be achieved overnight. From the larger hospitals to defend our historical referral base. And here with minimal investment, to the extent we can create that relationship and start working with the primary care in a very loose relationship, frankly, we've taken a step towards shoring up our market share, and this is from the larger hospital's perspective, with very little to almost no investment. Again, opportunity to increase missions. What are we looking to avoid? I think the big here is that as a rural hospital, we surely don't want to link with a hospital that might be the charity care hospital in the city, or some type of hospital that their brand doesn't do anything to help our brand. I think from a larger systems perspective, their biggest risk is they dilute their brand and their image because of poor quality at your hospital. And I think the other thing to avoid is just the expectation coming in. How many times just because the COO of the larger system sits on your board, does that mean all of a sudden now the physicians in your rural community are going to admit 100% of their tertiary services to this one hospital? I mean, it's just not going to happen. It's going to take much more work than that. So that's the first node on the value curve. The second node, the second node is around simple, straightforward. If we have access to, as rural hospitals, the purchasing network and power and skills and logistical support of the larger system, often we're able to save costs and improve and streamline our processes around supplies management. So here access to cost savings, savings and efficiencies of scale, focused contracts, group purchasing organizations, this type of thing. From the larger hospitals' perspective, they often they can get value. I was talking to Jerry Cotton down in Baptist in Jackson, Mississippi, and he was saying that for every rural hospital he has signs up, the Baptist system gets additional shared savings or gets additional savings through additional discounts. So clearly an opportunity there. Good neighbor reputation and lower costs through purchasing volume. Here's an opportunity to look good. And so this one's pretty straightforward. And obviously the situation here, the hospitals seek to lower costs of supplies, systems seeking to expand efficiencies of scale. I think the characteristics here are straightforward. You can take a quick look at them. Consolidation of suppliers, standardization of supply chain. Obviously the benefits are pricing that we have in rural now that we wouldn't tap into at all through our normal GPOs. We could also get improved supply chain management. We can have faster turnarounds. There's a number of things that we could do. We could have better inventory control, setting up our inventories on systems through perpetual inventory systems managed by the system. And so again, and then standardization of supplies where we can get further savings of costs. What to avoid: overcommitting resources, expectation that all our purchases are going to be on contract. And then the other is that by having another rural hospital, does that actually increase the inefficiencies of supply chain management? We got to stay away from that. The next area is, and now this next area is starting to get at kind of coordinating clinical care. So now we've gone beyond boardrooms and management teams to starting to coordinate with clinicians. Targeted initiatives or programs that improve access or efficiency. I think a perfect example here is swing bed. It's a great complementary service our rural hospitals can provide. It frees up bed capacity in the larger systems, and it's a great way that it involves case managers working with case managers and clinicians working with clinicians. That's a perfect example. I saw another example out in Indiana where there was an occupational medicine program, the system hospital that they partnered with the rural hospital to put into a large new automotive plant that was being built. So there's different targeted things, but again, it involves a little bit more operations, and now we're starting to kind of tighten it up a little bit. Some of the words here: targeted initiatives. The volume increases often are cost savings. Often we're going to get into informal agreements. And from the larger systems perspective, to the extent that they can expand their reach, now starting to get into clinical services, it absolutely improves the case findings. It brings in more cases in specialty services. If they want to create, if they have a heart center or a cancer center, having that support now out in rural hospitals increases the likelihood that those types of services are going to come back to that urban hospital. Again, frequent communication of frontline staff. Now we're starting to get a little bit into operations. Some of the situation here: a large system hospital is unable to support specialty services in the community. Referral hospital seeks to relieve bed pressure. These are just two examples. Characteristics: community hospitals care for lower acuity patients. Let me see, what do we want to talk about here? See, this is where it gets a little bit, a lot of words here, but I think you can see where we're going with this one. Some of the benefits, as we talked about, is broad geographical referral case or basis and case findings as we expand out into rural. The whole issue that if we can keep patients locally, we can have that access. The telemedicine type services that the larger systems can offer us in rural, as an example of a clinical collaboration. Swing beds are this huge opportunity. Clearly, that's one we're seeing develop most quickly in most relationships. What to avoid is insufficient resources, incomplete commitment, and failing to get buy-in of clinical staff. If we don't get case managers if we get the case manager in the rural hospital all on board with developing the swing bed program, and they go to sit down with the case manager in the urban hospital, and they just say, that's not going to work. I had one hospital I was working with, the case manager, they were trying to develop their swing bed program, and they went to the case manager in the larger system, and they pretty much said, well, we're not going to send you patients. Why didn't they say that? Oh, it was the craziest reason. Anyway, it had to do with some regulation that they were completely wrong on. But essentially, the rural hospital wasn't getting any swing bed volume at all, just because the case manager in the large system didn't understand the regs. Next area is and this is the one where I start to see, again, as I mentioned earlier, some real value that, from the rural hospitals that I see, it's kind of Chris Tilden's example here, the access to the human resources. So for the rural hospital, it's the access to financial and clinical resources that we just can't afford. We've got better decision making when we apply that expertise. And frankly, the interesting thing about it is that we can buy it on a kind of incremental cost basis rather than paying full price for the human resource director, the $120,000 human resource director, and those types of folks. I mean, we can have access to them and pay incremental costs only. The urban hospitals, to the extent we structure how do we pay for these services, reselling of these, and here we often see in this part of the affiliations, we can often get to a point where, especially within our critical access hospitals, we can get these home office cost allocations going on. And when we can start allocating large system costs to the critical access hospital, it essentially, for management type services, it essentially acts as an opportunity for that larger hospital to be paid for providing these services. We spread overhead costs of these super uber specialists, these administrative specialists. We can spread those costs so that the system hospital doesn't bear them all. And so anyway, this is one of these areas where I get to see real value add to rural areas. Again, situation, rural hospitals not able to recruit or afford specialized management expertise, and here are the ones that we list: revenue cycle management, accounting, human resources, IT, and other management expertise, the in-house legal, the corporate compliance, all of this. And frankly, the largest system hospital looking to do more with less, and then less with less. Sharing some of these costs with other hospitals in the system, huge opportunity. The characteristics, pretty straightforward here. Expertise shared between affiliates. We can adopt best practices. Hospital managers serve as consultants to each other. Daily interaction. So now we're starting to get much more interaction here. And that often contract department management. Benefits, again, straightforward. Purchased access to skilled professionals on an incremental cost basis only and not the full boat. One of the things that we had talked about was this growth of professional staff at multiple sites. So here what happens is because the human resource expert gets to go out and see different locations, they get to develop their own professional repertoire of services because they develop new skills and services by providing guidance to the affiliates. Here, where the home office costs may be allocated to affiliates, often we can get to the point of control and risk so that we can start to share home office. And that's where there's a real opportunity, especially with the critical access hospitals. Some of the things to avoid: not understanding differences in operations. I just listened to my good friend Daryl Weaver from Yazoo City, Mississippi, and he talks about the day the folks from the lab manager from Baptist went out and sat down with his lab's manager, and essentially was, wow, so you in this rural hospital, you're operating with this equipment and this poor level of ultimately with, you're working with sticks and stones out here. How can you even live each day and feel comfortable providing quality and how his, it's just, often our urban folks don't understand our rural model. Rural is not urban smaller. And another one to avoid is this is a good one, the forced purchasing of services. Farming out the B team to the affiliates. So the administrator or the administrative folks in the large system that are 2 years from retirement. The big system's just looking for them something to do, so what are they going to do? We're going to farm you out to the rurals because they don't really need that much help. And then Deduce Accountability. I came across this one. I was working with a system in upstate New York, and they owned a critical access hospital. And what was happening was the department manager, all of the department managers of the critical access hospital reported to all of the individual department managers of the larger system. And so what was happening, there wasn't really any one point of accountability at the critical access hospital. There was all of this direct contacts between the individual department managers of the critical access hospital to the system. And so what's happening, this hospital continued to lose money year after year. There wasn't any kind of organizational accountability at the rural hospital. And then, so we were able to get that changed, and the hospital, frankly, turned around a little bit. We had all the department managers have first responsibility to the site administrator at the critical access hospital. And just that change in kind of aggregating accountability at the critical access hospital really helped to go a long way. So here we are, we're halfway through the affiliation value curve. What we saw here, these were essentially the more operational value adds in a relationship. And frankly, we've got this thing now called the commitment gap. And what we've seen is to date, a lot of relationships have stopped at this level. We haven't figured out how to get beyond and into kind of the more strategic areas. And so we call this commitment gap, because once we step beyond here, it's going to be more expensive, it's going to require significant more levels of commitment, and frankly, the end benefit is a lot less certain, but in theory, much higher. Any thoughts? Can we stop here on the value curve? Any thoughts on kind of that first phase of it? Anybody out there?
I'm still here, but I don't have any questions.
Okay. So now what we're going to do is the next level is access to capital, and obviously the critical access hospitals that often, or excuse me, the rural hospitals often are operating on significantly less. We don't have those endowments. We don't have access, and right now the needs are IT, facilities, and physician recruitment. Those are your big ones. And a lot of times, especially the critical access hospitals that have been getting paid cost by Medicare for the last 4, 5, 6 years, they did not have the access profits to be able to enable the developing of a cash position. The interesting benefit to the system, if you think about it, they could either put their $30 million into the stock market or the bond market, being that they're a little bit more conservative, or as a, and this would be a passive investment, or they could invest it in rural hospitals and something that they could have much more active management over. Frankly, if we know the things about rural hospitals, I would want to make my investments in them, because I think the greater return is there, especially as we integrate our systems. So I think there's a huge opportunity for the urban hospitals in having more active investment portfolio than currently just letting it sit in the stock market. Clearly the situation is the rural hospitals' finances don't support the independent capital investments for facility and IT and physician recruitment. The regional center seeks diversification of its investment portfolio out of the stock market into something that we have some control over. Some of the characteristics here, the system can provide capital or guarantee the debt of the affiliates, so that the affiliates have access to new capital. I mean, I know Daryl Weaver, because they picked up some additional revenue in their home office cost report shift, they're looking at potentially developing a new facility or building a new facility, and they can do it on a standalone basis, even though they have a relationship with Baptist. And it's primarily because of a little bit of the backing, but then the USDA or HUD, they're going to be able to allow access to capital for these folks. Clearly, the benefits are the upgraded community hospitals. And for those of you who have followed the rural hospital replacement study that Stroudwater has done the last 6 years, I mean, with upgraded facilities generally results in increased volume, increased quality, increased physician recruitment, all which goes to make the combined system a much better system. Again, benefits of the affiliation, the growth of primary care and ancillary services due to more successful physician recruitment, new successful facilities, technology, quality, all of these things. I think the things we've got to be careful about is inadequate capital infusion. If we're going to be looking at a facility investment, let's not underinvest it. Let's do what's right for our community so that we can recruit the physicians in. Anyway, so those are some of the things. Next is technology. This is the big item right now these days with the EHR and meaningful use requirements. Critical access hospital looking to create a shared clinical and financial technology, new access to IT, and it's really what we're talking about here is within the larger system is standardizing best practices of IT use, both financial and clinical, across a larger group of hospitals. Often the systems hospitals have created some best practices, frankly around financial management accounting, around clinical quality reporting, around pure just clinical EHRs and things like this, that those best practices have already been established. Let's roll those out. And as we roll those out, we improve the likelihood of both financial and clinical success in both organizations. That's the theory. So what we're talking about here is affiliate and system hospitals that want a common information technology platform, EHRs, business and clinical operations. They enhance quality and gain efficiencies of scale. Again, that's kind of the aims here. IT support is provided by system. I was with a rural hospital, critical access hospital in Georgia a couple of years ago, and they had top of the line IT. They were steps away from EHR in a community that was very, very poor community. And the administrator of the critical access hospital essentially said, without this relationship with this system hospital, we would be absolutely nowhere with EHR, with technology. And so,
Eric?
Yeah.
Hi, this is Debbie in Alabama. I have so much to learn, but do you see this relationship primarily between the rural and perhaps their tertiary? Or if an urban hospital, I mean, how far out? Are there distance parameters that you would, I guess, warn against? Or
it's funny. I think that's a really interesting question, Debbie, because if you look at, say, for example, in North Carolina, there's 23 critical access hospitals in North Carolina. 21 of them are affiliated right now. Some of those affiliations spread over 100 miles. And ultimately, I think it's going to come down to how healthcare reform kind of plays out in terms of the adjacencies. I think to the extent that we look to create, I think an affiliation can happen on the operational level, kind of the left-hand side of the affiliation value curve, in distant relationships. I think to the extent we get beyond and get to the more strategic areas of the affiliation value curve, I think there has to be some physical adjacency. Anyone else have any thoughts on that? I'd be interested in what other people think. Is that fair, Debbie? Do you think,
that makes sense, and I can see it where the rural hospital is within a reasonable distance to the urban area, but for one that's isolated and far away, I'm just wondering how that affiliation can even begin, much less develop.
Yeah. I mean, I've seen hospitals, the larger systems, go after hospitals 100 miles away from them. But I think, and I just did this project last fall for a hospital that was considering it. And what we came away with, there was almost a two-tier affiliation strategy. One affiliation strategy were for those rural hospitals within a 50-mile radius, that we would likely be looking at them both to be affiliation relationship around the operational, but then the more strategic. So that was kind of one affiliation strategy. And then there was a second affiliation strategy for hospitals that were farther distant away, that we could still do things like farm out swing bed services or provide management expertise or lend our image in our franchise to. But if it got beyond that, getting specialists to go visit them and they're 100 miles away, I don't think that was going to work. So there was almost a two-tier affiliation strategy for this larger system hospital.
And that makes sense. Thank you.
Yeah. All right. So technology. We're good with technology. The physician. Here's the how do we get physicians in our rural communities and here in the affiliation value curve, what's interesting is it takes coordinated and routine access to physicians. Primarily, our rural hospitals have the primary care, but it's that specialist that we can't get out, and it's the specialist that's willing to provide or perform minor services and in our rural hospital. Those are the ones that we're really looking for, and that's where the value is to be gained. Within the system hospital, it's interesting because increasingly the larger systems will have to move toward an employed model on specialists for this to be successful. And because ultimately they're going to want to recruit in specialists that have responsibilities in rural hospitals, in their rural network, in their rural outreach. And frankly, it improves everybody's likelihood within the system of success to the extent we can do this. The situation here, patient migration to tertiary centers, and how do we keep our patients in our rural communities? The referral hospital essentially is consumed with low acuity. How can we keep primary medical services in our rural area out of the systems? It's the Colorado example I gave. How do we as larger systems focus on the tertiary stuff and farm out the primary stuff to our rural communities? And again, this is all about an abundance model where if we can farm out that primary medical stuff to rural to free up so that we have more capacity to do what we should be doing, everybody essentially wins in this relationship. The affiliate hospital characteristics obviously host specialty clinics with providers sponsored by system referral centers. And increasingly, like I said, it's got to be almost an employed model. One of the things that we're seeing reappear here are these regional PHOs, and where you have this integrated physician governance where our rural hospital physicians serve as members on these regional PHOs. One of the most successful PHOs I've seen in the country. I just had lunch with the CEO a couple of weeks ago. He's in here in Maine Med. What they did several years ago is they changed the PHO's primary focus in life from being a contracting agency, in other words, physicians join and they have access to third-party contracts, and they changed what they were going to do to focus on quality and patient safety and support for quality and patient safety in their primary care offices. And so what they ended up doing is they contracted with third-party insurers for some type of per member per month payment, and they used it to develop case managers and health coaches and people that ultimately were going to be supportive of the primary care. They created a chronic disease registry for all their primary care practices, and it was a really interesting tactic. They were getting paid for it by the third-party insurers, but it was a really interesting PHO. And I would think that if healthcare reform rolls out and we develop the ACOs, we are going to see a reformation of PHOs, but with a focus of quality and patient safety and supporting, and caring for chronic disease and things like that. And I think that's going to be kind of a part of how this is going to roll out. Obviously, some of the benefits here, physicians perform cases at community hospitals. We've got to maintain that. We've got to maintain the support for our rural hospitals. specialty services are consistently available in our local communities, but and then with this right patient, right service, right town. I mean, I think that's kind of a really important piece of this. And then the close integration between our specialty system, physicians and the overall system through a PHO or other means, employment, however that works out. Obviously, what to avoid is the specialists that just strip out services, the revolving door of physicians, lack of support from our local medical. We could have all the specialists sent out from our system hospital, but if our local medical staff doesn't support them, it's not going to work for anybody. The last one is this clinical integration. You know, somewhat undefined, but I think of it as a true model in which the time and expense and resources put into developing evidence-based protocols at the larger systems are able to be farmed out into rural affiliates to the extent where you walk into the front door of your rural hospital, it's like walking into the door of you know, the Mayo Clinic or something like that, or whatever system you choose to affiliate. If ACOs occur, then this clinical integration piece is going to be the most important, because now we're talking about true disease management, population health management, where I think the value here is not even, you know, these two values are not, you know, nowhere near where the true value is going to be, which is going to be, you know, way up here and way up here. Obviously, overall hospitals and the entire system waiting, you know, really wanting to create this high-performing system. Emphasis providing care at local hospital when possible. There's facility technology, clinical protocols aligned throughout the entire system. Quality outcomes publicly reported, data is mined. It's everything that we could think about that it creates a population-based management system. The community hospital to our rural hospital becomes the front door to any treatment that's, you know, in best practice systems have been developed. The implementation of the medical home concept is possible here. Again, our rural hospitals are this essentially primary care home in that they are primary care physician based. Some of the things to avoid here, I think these are the scariest of all, is that that short-term market demand influencing operating models. For example, if volumes drop 10% in Q3, all of a sudden we go in a completely different direction. We're pulling back all referrals from the rural hospitals because we need them all in the urban hospital. Dependency on one leader's vision. I just had this conversation out in Kansas a couple of weeks ago where you know, essentially I said, this one scares me the most. The current administrator was passionate about moving towards this, partnering with all of the rural hospitals. And I said to the rural hospitals, it's got to go way beyond just this one CEO's passion. It's got to be ingrained within the organization that this is the strategy we want to take. So thus is the affiliation value curve. Again, I like to look at it as a tool to I like to ask hospitals to sit down with it and evaluate their strengths and weaknesses on each one of those. You know, sit down with their board and go across. What's our image look like? What is our access? What's our GPO contracts look like? What's you know, are we providing the services? Do we have swing bed volume in here? You know, and just move right across the curve and evaluate strengths and weaknesses. To some extent, you know, I had the hospital. I was telling you about the hospital, the Tweener Hospital in Maine. They did this, and what they found is on a ranking basis, they were probably 8, 9, or 10 on every single one of the nodes of value. They still were interested in affiliating, but what they said essentially is we don't need to affiliate with a tertiary care that's bigger or better than us. We are bigger. I mean, we are really good, and we are very high value on all of these. And so they were looking to do is affiliate with hospitals their size so that they didn't get caught up in some of the politics and kind of sometimes the urban hospitals that have difficulty making decisions quickly. It was just really interesting. But like I said, I encourage folks to kind of assess their own strengths and weaknesses in a very kind of just again, that framework allows you to objectively assess your kind of need for affiliation-like value benefits. Does that make sense? Thoughts and comments on that curve? I told you it's pretty heavy from a theory perspective, but again, I think that there's huge value, just as the one COO of the large system in Mississippi said, the value's in the details of that. I want to share with you a way to think about it. Here's a great slide for an accountant like me. Lots of numbers, a couple words, more numbers. What I was working with, I was called in because there was a critical access hospital in Pennsylvania. They essentially broke even on operations, and they were kind of going cap in hand to a potential to a larger system hospital, essentially saying, "Can you just take us over? Because woe is us. We're a rural hospital. Here's our bottom line, our financial statements. We essentially lose $211,000 on operations, as you can see here. They lose. Here's their revenues right here, and here's their expenses. And guess what? They lose $200,000 on operations, like many of our rural hospitals. They've got a little bit of non-operating income. They get some grants and some contributions, and so their bottom line is about $270,000. They do have some cash and liabilities, but overall they look like a lot of us. So this is the way they look at themselves. They did not consider looking at themselves in terms of the value they can provide relative to the value curve. They were looking more at their P&L and saying, here's the value of us to somebody else. What I'd like to do is turn around the math on this and say, let's not look at the value you just in your income statement. Let's look at you as on a contribution margin basis. What does that mean? The contribution margin does a couple of things. One, it looks at you more on, it backs out non-cash related expenses. So in EBITDA, earnings before interest, taxes, depreciation, amortization. Let's remove some of these. Let's look at it from a cash position. Let's consider non-operating revenue. Shoot, if we're getting contributions as a single, as an independent, we're likely to continue to get them as a system. Let's look at cost-based revenue. If this was a critical access hospital, so let's look at possibly a home office cost report shift from the larger system to us for some of this distribution of management expertise and things like that, and the revenue associated with that. And then, oh, by the way, let's look at the effect of us as a rural hospital, either expanding your market share by 5% or protecting your market share with a net effect of a 5% gain. And so the following page, and you're going to have to get real close to your screen here because there's lots of little itty-bitty numbers here. But what we did is I took this critical access hospital's financial statements from just a pure P&L perspective, as we're generally used to looking at them, and turned it into a contribution margin. And so the first part of that is, as you can see, let's see, where's my little arrow? There it is. You guys following this little green arrow, spinning it all around? You start off with the operating loss of $211,000. Now we're going to add back our depreciation expense. In that $211,000 loss, there was $500,000 of depreciation. Let's add that back. Let's add in our non-operating income, these grants and things like that. So now we go from an operating loss of $211,000 to a gain of about $820,000. And so that's kind of the first level of the look. The second thing, is kind of part B of this, is that what we ended up doing is we estimated the impact of the urban hospital allocating administrative and general costs to this critical access hospital. And what we estimated is that they would allocate about $1.6 million in overhead from theirs to the critical access hospital. The cost-based reimbursement for this hospital was about 30%, and actually that was light because this was only Medicare. They also had a bunch of Medicare Advantage plans that also paid on a cost basis that I did not pick up when I did this analysis. So this number was probably ends up being about another couple $100,000 more than it is. But essentially, if this critical access hospital got $1.6 million allocated to it through the cost report, if their Medicare payer mix, instead of being 29%, was actually 50%, you're talking about another $800,000 of new value added, which takes it from 1.3, now we're probably talking about $1.7 million of value. The third piece, and this applies whether you're a critical access hospital or rural PPS hospital, essentially what we did is that we looked at the discharges from the rural hospital service area, and there was 3,100 discharges. Currently, the large system hospital captured about 56%. So they captured about 1,700 discharges from this rural hospital service area. On an inpatient basis, this hospital's average case payment amount was around $9,000. So from an inpatient perspective, there was about $16 million of revenue coming out of the discharges from the critical access hospital service area. If you gross it up, this section right here essentially grosses that up for outpatient service. It's an estimate, it's a proxy of outpatient. You're coming up with net revenue, cash, of about $32 million. On a contribution margin, in other words, so what are the incremental costs of providing this service, or what is the incremental profit taking out the incremental costs? And we estimated a contribution margin about 60%. So for the 56% market share in this critical access hospital service area, the net effect to this system, larger hospital, is about $19 million in bottom line. If you divide that by the 56%, you come up with every percentage point change in market share from this critical access hospital service area resulted in about $350,000, $340,000 of bottom line. The last assumption here was saying that if this critical access hospital either got on board with you and started supporting you more fully, or they went and were affiliated with another system hospital out, not yours, and they could pull 5% of your service area away, we assumed that there was about a 5% shift in market share that could happen one way or the other to the extent you weren't supporting. Bottom line in here is that the benefit to this critical access hospital being part of this larger system to the system was about $3 million. Now interesting to note that last year, 2010, the big system's bottom line was $3 million. So it was really interesting. I presented this talk to the board of the 600-bed system, and then I presented this presentation to the board of the critical access hospital about an hour later. By the time we got done, both boards were completely on board. Let's just go. We're gonna work together. Let's figure out a way to affiliate. It was really interesting. So really, this contribution margin is a really interesting way of thinking about the value rural hospitals can provide. And again, it's one of these, don't ever think that you don't have super high value to anybody that you're talking to. Thoughts, questions on that piece? Because this slide 636 is pretty much just words to support all of those great numbers that we just looked at. The last area I just want to talk a little bit about is how do we create successful relationships, whether they're collaborations or affiliations, and I think the first is to set what is the vision for the future for both organizations, where are we both going, and what's it going to look like together. Set clear goals and objectives from the affiliation from both partners. We want to know from the boards of each organization what's the strategy, where are we going with this thing? Like we had talked about earlier, if the goal here is if the rural hospital is 100 miles away, to be successful on the outside, if we're going to merge with a hospital 100 miles away, we have to set the expectation going in that we are only going to be able to offer these types of things. we are not going to get in and get you specialist physicians. We're not going to get in and implement our evidence-based protocols. And we'll help you around management expertise. We'll help you on one-off. We'll get your GPO in place. So I think that there's a clear expectation going in. What are the goals of both partners? An objective assessment of the range of affiliation options. What is the best method to affiliate once we understand what the goals are, and then create this win-win relationship. This next slide is really important because when you're sitting down to talk with anybody, and what we try to do is ask both organizations, the boards of both organizations, these questions here. Why are you considering an affiliation? Why are we even talking about this? And it's really important to get that understanding both at the board of the larger hospital and the board of the rural hospital. Is it to expand services? Is it to improve our contracts? Is it to access capital? I think we really have to consider these things. Here is where I think when you sit down with the affiliation value curve and plot out your strengths and weaknesses on that curve, the whys, why are we even thinking about this, jump right out at you. What do you need or want out of an affiliation? What are those things that we really are looking to achieve? Flat out, are we just looking for capital? Are we looking for managed care? Do our managed care contracts absolutely stink? We know that system hospital is giving an extra 50% on its physician fee schedules, and having better access to services. The managed care, the shared services. This is the the expertise, the human, the specialist, the administrative specialist at the system hospital. The next question that both boards really have to understand is, what are you willing to give to the partner organization? And then what are you unwilling to give? What are you willing to give? Some degree of control. What are you unwilling to give? What we hear most often here is what are we unwilling to give up? Our independence. And how do we maintain some type of our independence as a rural? How do we maintain our local decision rights so that we're not cast within this big old system and decisions flow like molasses? So what are we unwilling to give up? And then finally, are there any constraints? This hospital where I was in Pennsylvania on Thursday and Friday last week, they represent 56% of the service area market share. If they affiliate with this rural hospital, somebody's going to have to look at that. The state AG's office or something. But are there regulatory constraints? Are there financial constraints that we got to think about? So these set of questions here are really important to help organizations go into a relationship with eyes wide open. Why are we doing this? What are we willing to give up? What are we looking to get? What are we unwilling to give up? And frankly, are there any constraints that are going to keep us? Are physician relationships going to keep us from making this happen? That is 75 minutes of consultant talking. How'd it work for you?
This is Chip Denton again. I enjoyed it. Eric, I guess I've got a question. A lot of what you talked about really sounded more like a hub and spoke or kind of deal, but do you have any sense of the proportion of size that you would have to be a hub or a scope of services?
Well,
in North Mississippi, we're covered up with modest-sized hospitals.
Mm-hmm. I mean, that's an interesting question, Chip, because that was what the hospitals in Maine, kind of the one hospital I was working with last spring, what they essentially said was, we're a medium-sized hospital. I believe they're, what are they? I think they're about an 80-bed hospital. And they said, we do a lot of this stuff really well, all along the affiliation value curve. They scored themselves very well. So we don't need to affiliate with a hub and spoke. We still think that there's significant value in affiliating with somebody. It's not necessarily a large system, and it's not necessarily a small system. So they sought out hospitals similar in size to them that they could have a relationship with and kind of work on things. It was kind of a really interesting way of thinking about the affiliation value curve. But I do think that my examples I were giving were primarily hub and spoke because that's what we're seeing coming down the pike right now. What are your thoughts, Chip?
Well, I tend to agree with you, but I get back to the size issue, especially in some of the poorer states where, if you're not in Mississippi, if you're not in Jackson, Hattiesburg, or the Gulf Coast, maybe Meridian, there's just not that many strong economies. We're all struggling with, my impression is, we're probably all disproportionate share hospitals.
Mm-hmm.
Kind of put it in perspective. I mean, we're all heavily loaded with Medicare, Medicaid, and charity patients. And it's certainly in Mississippi, Blue Cross thinks the threshold of payment is the 92% of cost that Medicare pays. So, I mean, it's other places. I know Alabama's.
Yeah, they're even rougher than you are. Their Blue Cross plan's pretty rough.
Certainly as it relates to Blue Cross. I mean, Blue Cross, I think, in Alabama's got about a 90% market share of the commercially insured patients.
And they pay a fraction of Medicare essentially. That's why there's no critical access hospitals. There's 2 critical access hospitals in Alabama because of that.
Yeah. Anyway, it's a very challenging and good presentation. I appreciate your time and willingness to do it.
It's one of these topics. I gave this talk last week, the week before. I gave it to a sister. I was out in Kansas where this hospital. It was originally they had a network of 16 critical access hospitals around a larger hub hospital, as you would refer, Chip, and they understand where all of this healthcare thing's going, and they want to take this whole network and take it up a whole new level by looking at this affiliation value curve and working with all of their 16 hospitals on taking steps towards going, kind of moving to the right. I had a call last fall by a larger system in Nebraska who have 40 critical access hospitals and a network around them. Not all critical access, rural hospitals. And they have a loose network, and their director of business development called me to say, I just want to let you know, we got a copy of your affiliation value curve. We've plotted every single one of our 40 rural hospitals on this curve because it helps us understand where, kind of where we could help them, where they can help us, et cetera, et cetera. So, this whole thing is really coming down, and I think for the next 18 months, we're going to see all kinds of activity in this area. So, anyway, I'll stop talking.
Eric, this is
Yes.
Kathy in Alabama.
Hey, Kathy in Alabama.
How are you? I've got a room full of people, but they don't know what I'm going to say. I'm have recently moved from Florida to Alabama, so with a small rural hospital versus a critical access hospital, when you look at affiliation and adding value,
Mm-hmm.
is there additional value or more value to be a critical access? And if you consider opportunities for rural grants, does that play into critical access and mileage from an affiliate?
All right, let me answer the first one because I don't really understand the second one. So I think what's happening right now is increasingly there's a feeding frenzy of the larger systems around the critical access hospitals. And the reason is people are really starting to figure out this cost report, home office allocation shift.
Mm-hmm.
And so there's a feeding frenzy. I mean, in Mississippi, pretty much critical access hospitals, anyone that even hints of wanting to affiliate is gobbled up in a heartbeat. You know, usually it usually ends up being a very beneficial relationship too. So it's I mean, I think it works out very well in Mississippi.
Yeah.
I think that what's going to happen over time, and this is an interesting point of debate, we can debate this, is that I think as we get down, you know, that third section of the contribution margin that we had talked about,
yes.
the contribution margin or incremental profit derived to the system from changes in market share out of the rural affiliates service area.
Mm-hmm.
I think ultimately that is going to be the bigger play as we walk on down healthcare reform angle. And my basis for that is around the medical home concept of many of our rural hospitals. You know, one of the interesting things about the ACO rules that came out, the proposed rules that came out a couple months ago, was the fact that a hospital can be in multiple ACOs, but a physician, a primary care physician, can only be in one. Essentially what it's saying to hospitals is that your physicians are more important than you are. That's the way I looked at that.
Yeah.
And so what we really want to do in rural is really work up with our physicians, link up to our physicians, you know, focus on the medical home concept in our rural areas, in our rural communities, and then we ultimately are going to have very high value to anybody looking to spread to the rural areas. That's my opinion. Other people can jump in here because this is an interesting discussion. And Kathy, I have no idea how to answer your second question.
Okay.
Eric, expand on that comment you made about the physicians being more important than the hospitals.
Well, what it's saying is that, I mean, what part of the rules say is that a physician, your primary care physicians, can only be in one ACO, where a hospital can be in multiple ACOs. In other words, the dollars are linked in the future to the extent these ACOs roll out, and I still think that there's very likely that this is going to happen once CMS tweaks its rules. The dollars are ultimately linked to the physician and the physician's patients. They're not necessarily linked to you as a hospital. And so, you know, most of our rural hospitals are not going to form their ACOs. Chip, I don't know what size your hospital is, but most rural hospitals are not going to form their ACOs. So they're going to be a partner in or two or, you know, some type of you may not even have a relationship with an ACO. But the doctors are the ones that are going to be really being interested in being gobbled up.
Well, you think about, I was filling out the questionnaire thing about future things. And
Do you need any money related to that, or you know, at least on the top part of that questionnaire?
well, there is. I mean, I would like, one of the comments I made on the questionnaire, and I would like to have, and I'm not very knowledgeable about them. I've got an idea about what it all means, but if we could establish a methodology to have like a roundtable discussion about what a lot of different people, different parts of the country, among us, those of us that are rural hospitals, are seeing and or thinking about the whole concept of ACOs. Yeah. Because it's bigger than just the physician versus the hospital issue.
Yep.
This harkens back, in my mind, to 1974-75 when Nixon was going to fix health care by creating HMOs. How many of those community HMOs exist anymore? Zero. Yeah. The problem is who can bear risk and who has the balance sheet to bear risk. That's that's kind of an overarching issue.
Yep.
And then the other piece is more and more of us move to physician-employed models. How do they fit? Because, you know, I'm sorry I've ever hired my first doctor, but I regrettably say I've got a bunch of them on the payroll now.
I think that's going to turn out to be a wise investment in the next 5 years.
I bet you it's going to be another disaster.
I think we need to have this roundtable discussion.
all over again. They'll burn up all the cash, and as soon as there's a window of opportunity, they'll jump out and go right back into competition against us. They are true small market, small business entrepreneurs. They're not trained, they're not interested, they're not committed to working in organizations.
It'll be interesting. I think, you know, to respond to your quest for an open forum discussion on this, I know Task, who Allison works for, they're kind of pulling together information right now on kind of the impact of ACOs and what people are thinking. I just got an email from Sally asking about this, and I'm actually giving a couple talks. I'm giving a talk in July, early July in Mississippi on this topic, and I'm giving another one in West Virginia later in July. So this is a very relevant topic, and I haven't figured out quite what I'm going to say yet.
Eric.
Yeah.
It's Kathy again.
Hey, Kathy again.
Can you give us we've got some people sitting at the table, and we'd really like a definition of ACOs then.
Well,
It's a unicorn.
Oh, come on now. We've all read that one by now. The feds have put out proposed rules on ACOs, and you know, obviously the proposed rules just last week, the big folks, you know, Kaiser Permanente, those, the Geisinger system, all that the feds were very bullish were going to jump into these ACOs literally came down and said these ACOs are going nowhere as currently proposed. They're just too onerous. It's going to cost $1 million to set these things up, and the return on investment is suspect. So, you know, the feds right now have proposed rules on these out there. I think that they're going to change significantly before the final rules come out. But we had an in-house firm discussion about ACOs. Obviously, you know, the first thing is ACOs is essentially the ACO stands for another consulting opportunity, but that's the real definition of them, if you didn't know that. But what we said is let's stop using ACOs as the definition. Let's look at more accountable care. And think of accountable care as anything where a provider can monetize value created from increasing quality and reducing cost. So I just said a mouthful there, where a provider can monetize the value created from increasing quality and decreasing cost. And when you look at accountable care in that framework, accountable care is anything from you know, value, pay for performance around value, reducing inappropriate admissions or readmits. It could be the ACOs as the feds. It could be providing accountable care plan designs around your ERISA employees, and it could all be all the way to provider-sponsored health plans. So there's a whole range of what accountable care could be if you remove the accountable care organization language that the feds have put on it.
Mm-hmm.
So anyway, that's a long way of saying it. I'm concerned that we're running over, and Allison's going to cut me off here. So
I would try really hard not to cut you off.